Welcome to our comprehensive journey through cardiovascular medicine. In this video, we'll explore the essentials of heart health, focusing on hypertension, ischemic heart disease, heart failure, and related cardiac conditions. Whether you're a medical student, healthcare professional, or just curious about how the heart works, this series will guide you through the most important concepts, clinical features, investigations, and treatments. Let's begin by understanding why cardiovascular diseases are a leading cause of morbidity and mortality worldwide, and why mastering their management is crucial for every clinician. The cardiovascular system is at the core of human physiology, responsible for delivering oxygen and nutrients throughout the body. Disorders of this system, such as hypertension, ischemic heart disease, and heart failure, can have widespread effects. In this section, we'll outline the major categories of cardiovascular diseases, their risk factors, and the impact they have on overall health. Understanding the basics, we set the stage for deeper dives into specific conditions and their management. Hypertension, often called the silent killer, is one of the most common cardiovascular disorders. Many patients remain asymptomatic until complications arise, making early detection and management vital. We'll discuss how hypertension is diagnosed, why it's so dangerous, and the importance of routine blood pressure monitoring. Understanding the difference between primary and secondary hypertension is key, as it guides both investigation and treatment strategies. Managing hypertension isn't just about medications. Non-pharmacological measures play a crucial role in controlling blood pressure and reducing cardiovascular risk. Lifestyle modifications such as adopting the DASH diet, reducing salt and saturated fat intake, regular physical activity, weight management, and quitting smoking are recommended for all patients with hypertension and prehypertension. Even a modest reduction in systolic blood pressure can significantly lower the risk of stroke and heart disease. These interventions form the foundation of hypertension management and are often the first step before starting drug therapy. While most cases of hypertension are primary, it's important to recognize secondary causes, as treating the underlying condition can resolve the high blood pressure. Common secondary causes include coarctation of the aorta, pheochromocytoma, chronic pyelonephritis, polycystic kidney disease, renal artery stenosis, Cushing syndrome, thyroid disorders, hyperparathyroidism, and primary hyperaldosteronism. Each has distinct clinical features and requires targeted investigations, such as imaging, hormone assays, or specialized scans. Identifying these causes is crucial, especially in young patients or those with resistant hypertension. Severe hypertension can present in various ways, but many patients remain asymptomatic and are only diagnosed during routine examinations. When symptoms do occur, they may include headaches, dizziness, polyuria, or even signs of organ damage such as left ventricular hypertrophy or fundal changes in the eyes. Specific features can point towards secondary causes, such as radio-femoral delay in coarctation of the aorta or paroxysmal headaches in pheochromocytoma. Recognizing these clinical clues is essential for timely diagnosis and management. Thorough workup is necessary to assess the severity of hypertension and identify any secondary causes. Basic investigations include urine analysis, blood urea and creatinine, serum electrolytes, blood glucose, lipid profile, ECG, and chest X-ray. Additional tests are tailored based on clinical suspicion, such as hormone assays for endocrine causes or imaging for renal artery stenosis. These investigations not only help confirm the diagnosis, but also guide treatment decisions and monitor for complications. Pharmacological management of hypertension involves a variety of drug classes, each with specific indications and side effect profiles. Commonly used medications include thiazide diuretics like chlorothalidone, loop diuretics such as furosemide, beta blockers like propranolol, and ACE inhibitors such as captopril. It's important to tailor drug choice to the individual, considering comorbidities and potential adverse effects, such as electrolyte disturbances, cough, or postural hypotension. Monitoring and adjusting therapy is key to achieving optimal blood pressure control. Hypertensive emergencies are life-threatening situations where blood pressure rises rapidly, leading to acute organ damage. Examples include acute aortic dissection, pulmonary edema, acute coronary syndrome, and hypertensive encephalopathy. Management requires careful blood pressure reduction, usually with intravenous medications like labetalol, nicardipine, or nitroprusside. The goal is to lower mean arterial pressure by no more than 20–25% within the first hours, avoiding rapid drops that can cause hypoperfusion. Close monitoring is essential to prevent complications. Ischemic heart disease, IHD, encompasses a range of conditions caused by reduced blood supply to the heart muscle, most commonly due to atherosclerosis. It is the leading cause of death globally. Understanding the etiology, risk factors, and pathogenesis of IHD is crucial for prevention and management. We'll explore how coronary artery narrowing leads to myocardial ischemia and why early identification of at-risk individuals can save lives. Risk factors for IHD are broadly classified as modifiable and non-modifiable. Modifiable factors include hypertension, diabetes, dyslipidemia, smoking, obesity, and sedentary lifestyle. Non-modifiable factors are age, male gender, and family history. Additional risks include chronic kidney disease and inflammatory conditions. Addressing these factors through lifestyle changes and medical management is the cornerstone of IHD prevention. Stable angina is characterized by chest discomfort brought on by exertion or emotional stress and relieved by rest or nitroglycerin. The pain is typically described as constricting, squeezing, or heavy and may radiate to the left arm, neck, or jaw. Episodes usually last a few minutes and are predictable. Recognizing these classic features helps differentiate stable angina from other causes of chest pain. Diagnosis of stable angina relies on a combination of clinical history and investigations. An ECG may show normal findings at rest, but can reveal ST depression or T-wave changes during an attack. Stress testing, echocardiography, and coronary angiography are used to assess the extent of coronary artery disease and guide treatment. These investigations help stratify risk and determine the need for revascularization. Managing stable angina involves both lifestyle modifications and pharmacological therapy. Patients are advised to stop smoking, adopt a heart-healthy diet, exercise regularly, and control weight. Medications include nitrates for symptom relief, beta blockers or calcium channel blockers for long-term control, antiplatelet agents like aspirin, statins for lipid management, and antihypertensives as needed. In severe cases, revascularization through PCI or CABG may be indicated. Microvascular angina, also known as cardiac syndrome X, presents with angina-like chest pain and evidence of myocardial ischemia on stress testing, but normal coronary angiography. It is more common in diabetics and women, often due to endothelial dysfunction. Treatment focuses on lifestyle modifications, glycemic control, beta blockers, calcium channel blockers, nitrates, and sometimes ranolazine. Psychological support is also important, as stress can worsen symptoms. Unstable angina and non-ST elevation myocardial infarction, NSDMI, are acute coronary syndromes caused by partial occlusion of a coronary artery. Symptoms include chest pain at rest, new-onset angina, or increasing frequency and severity of angina. ECG may show ST depression or T-wave inversion, and cardiac biomarkers are elevated in NSDMI. These conditions require urgent medical attention and aggressive management to prevent progression to full-thickness myocardial infarction. Acute myocardial infarction, MI, is diagnosed based on clinical presentation, ECG changes, and cardiac biomarkers. Classic symptoms include severe, prolonged chest pain radiating to the arm or jaw, often accompanied by sweating, nausea, or breathlessness. ECG findings may show ST elevation, new left bundle branch block, or pathological Q waves. Cardiac enzymes like troponins and CKMB confirm myocardial injury. Early diagnosis is critical for timely intervention. The ECG is a vital tool in diagnosing and localizing myocardial infarction. ST elevation in specific leads indicates the affected area of the heart, such as anterior, inferior, or posterior walls. Reciprocal changes, new left bundle branch block, and the development of Q waves provide further clues. Recognizing these patterns helps guide immediate management and predict complications. Cardiac biomarkers are essential for confirming myocardial infarction. Troponins I and T are the most specific and sensitive markers, rising within 4-6 hours and remaining elevated for up to 10 days. CKMB, ASD, LDH, and myoglobin are also measured, each with distinct timelines. Serial measurements help assess the extent of myocardial damage and detect reinfarction. Immediate management of ST elevation myocardial infarction, SDMI, includes attaching a cardiac monitor, securing IV access, and providing oxygen. Aspirin and clopidogrel are given as loading doses, followed by sublingual nitroglycerin and IV heparin. Pain control with morphine and beta blockers is also initiated. Early reperfusion therapy, either by primary PCI or fibrinolysis, is crucial to restore blood flow and minimize heart muscle damage. Storing blood flow to the affected heart muscle is the primary goal in acute MI. Primary percutaneous coronary intervention, PCI, is preferred if it can be performed within 90 minutes. If PCI is unavailable, fibrinolytic therapy with agents like alteplase, streptokinase, or tenecteplase is initiated within 30 minutes. The choice depends on timing, facility availability, and patient-specific factors. Early intervention improves outcomes and reduces mortality. Complications following myocardial infarction can be life-threatening. These include arrhythmias, heart failure, cardiogenic shock, pericarditis, and thromboembolism. Management involves supportive care, medications like ACE inhibitors and beta blockers, and sometimes mechanical support such as intra-aortic balloon pumps. Early recognition and prompt treatment of complications are essential for improving survival and quality of life. After an acute MI, rehabilitation and secondary prevention are key to reducing recurrence. Patients are advised to restrict physical activity initially, then gradually resume exercise. Lifestyle modifications, ongoing medications, aspirin, beta blockers, ACE inhibitors, statins, and regular follow-up are essential. Addressing risk factors like obesity, smoking, and high cholesterol helps prevent future cardiac events. Heart failure occurs when the heart cannot pump enough blood to meet the body's needs, either due to impaired filling or ejection. Common causes include hypertension, myocardial infarction, valvular heart disease, and cardiomyopathies. Understanding the underlying etiology is crucial for effective management and improving patient outcomes. Symptoms of heart failure include breathlessness, orthopnea, paroxysmal nocturnal dyspnea, fatigue, and swelling of the legs or abdomen. Signs may include raised jugular venous pressure, basal lung crepitations, S3 and S4 heart sounds, and peripheral edema. Recognizing these features helps in early diagnosis and timely intervention. Comprehensive evaluation of heart failure includes blood tests, ECG, chest X-ray, echocardiography, and sometimes cardiac catheterization. These investigations help determine the cause, assess the severity, and guide treatment. Biomarkers like BNP are useful for diagnosis and monitoring response to therapy. Acute pulmonary edema is a medical emergency characterized by sudden breathlessness, cough with pink frothy sputum, and hypoxia. Management includes sitting the patient upright, providing high-flow oxygen, administering nitrates and loop diuretics, and using non-invasive ventilation if needed. Identifying and treating the underlying cause, such as myocardial infarction or arrhythmia, is essential for stabilization. Long-term management of chronic heart failure focuses on controlling symptoms, preventing progression, and improving quality of life. Key strategies include salt and fluid restriction, regular monitoring, and medications such as ACE inhibitors, beta blockers, diuretics, and aldosterone antagonists. Device therapy, revascularization, or transplantation may be considered in advanced cases. Several medications are used in heart failure, each with specific dosing and potential side effects. Furosemide, 2040 mg OD-BD, can cause electrolyte imbalances. Enalapril 2.520 mg BD may lead to cough or angioedema. Bisoprolol, 1.2525 mg OD, can cause bradycardia, while spironolactone, 12.525 mg OD, may result in gynecomastia or metabolic acidosis. Regular monitoring and dose adjustments are essential for safety and efficacy. Atrial fibrillation, AF, is a common arrhythmia characterized by an irregular pulse. Patients may present with palpitations, breathlessness, fatigue, or even thromboembolic events. Causes include rheumatic heart disease, ischemic heart disease, hypertension, and thyrotoxicosis. Evaluation involves ECG, echocardiography, and assessment for underlying causes. Management depends on hemodynamic stability and includes rate or rhythm control, anticoagulation, and sometimes cardioversion. Management of AF includes immediate synchronized cardioversion for unstable patients. Stable patients are managed with rate control using beta blockers, calcium channel blockers, or digoxin. Rhythm control may involve pharmacological or electrical cardioversion. Long-term anticoagulation is essential to prevent stroke, especially in patients with high CHA-DS2 VASC scores. Refractory cases may require ablation or device therapy. Pulmonary embolism, PE, presents with sudden breathlessness, chest pain, and sometimes hemoptysis or syncope. Risk factors include recent surgery, immobilization, malignancy, pregnancy, and genetic thrombophilias. Early recognition is vital, as PE can rapidly progress to right heart failure and death if untreated. Diagnosis of PE involves a combination of clinical assessment, D-dimer testing, ECG, and imaging, such as CT pulmonary angiography or Doppler ultrasound. Classic radiological signs include Hampton's hump and Westermarck sign. Early and accurate diagnosis guides prompt initiation of therapy and reduces complications. Management of PE includes supportive care with oxygen and hemodynamic support, anticoagulation with heparin or LMWH, and sometimes thrombolytic therapy for massive PE. Oral warfarin is started for long-term prevention, with an INR target of 2.530. Surgical embolectomy or IVC filters may be considered in select cases. Early intervention is key to improving outcomes. Mitral stenosis is most commonly caused by rheumatic heart disease and leads to increased left atrial pressure, pulmonary congestion, and reduced cardiac output. Symptoms include breathlessness, fatigue, palpitations, and hemoptysis. Physical findings may include a tapping apex beat, mid-diastolic murmur, and signs of right heart failure in advanced cases. Complications of mitral stenosis include atrial fibrillation, pulmonary hypertension, right heart failure, systemic thromboembolism, and rare conditions like Ortner's syndrome. Early identification and management of these complications are crucial to prevent morbidity and mortality. Diagnosis of mitral stenosis involves ECG, showing P mitral, right ventricular hypertrophy, or AF, echocardiography to assess valve area and pulmonary pressures, and chest X-ray for left atrial enlargement and pulmonary congestion. Transesophageal echocardiography may be used for detailed valve anatomy and detecting atrial thrombi. Treatment of mitral stenosis includes medical management for symptoms and complications, such as diuretics for heart failure and anticoagulants for AF. Surgical options include balloon mitral valvotomy for suitable patients and valve replacement for those with severe calcification or regurgitation. Lifelong follow-up and prophylaxis for infective endocarditis and rheumatic fever are important. Mitral regurgitation can be acute or chronic, resulting from conditions like infective endocarditis, rheumatic heart disease, or myocardial infarction. Symptoms include breathlessness, palpitations, and signs of heart failure. On examination, a pansystolic murmur and displaced apex beat are characteristic. Early diagnosis and management are essential to prevent progression. Workup for mitral regurgitation includes ECG for AF, chest X-ray for valve calcification, and echocardiography for vegetations, valve defects, and regurgitation severity. Blood tests may show leukocytosis or elevated inflammatory markers in infective causes. Blood cultures are essential if endocarditis is suspected. Medical therapy for mitral regurgitation focuses on symptom control and preventing complications. This includes salt restriction, diuretics, ACE inhibitors, beta blockers, aldosterone antagonists, and vasodilators. Nitrates and diuretics help reduce preload, while rheumatic fever and infective endocarditis prophylaxis are important in at-risk patients. Surgical intervention is considered for severe mitral regurgitation, especially when symptoms persist despite medical therapy or when there is evidence of left ventricular dysfunction. Options include valve repair or replacement, with the choice depending on valve anatomy and patient factors. Mechanical valves require lifelong anticoagulation, while bioprosthetic valves are preferred in older patients. Long-term prophylaxis is essential in rheumatic heart disease to prevent recurrence and complications. Benzathine penicillin G is administered intramuscularly every 3-4 weeks, with the duration depending on the presence of carditis or valvular disease. Infective endocarditis prophylaxis is indicated for high-risk cardiac conditions undergoing dental or surgical procedures. Cardiovascular diseases require a holistic approach, integrating lifestyle changes, pharmacological therapy, and timely interventions. Early recognition of symptoms, appropriate investigations, and individualized treatment plans are key to improving outcomes. Regular follow-up, patient education, and secondary prevention strategies help reduce recurrence and enhance quality of life. Thank you for joining this comprehensive overview of cardiovascular medicine. We've covered hypertension, ischemic heart disease, heart failure, arrhythmias, and valvular disorders, emphasizing the importance of early diagnosis, evidence-based management, and prevention. Remember, heart health is a lifelong journey, and staying informed is the first step toward better outcomes for patients and communities.